because it will reduce bleeding. Here we are removing the prosthesis, and it's really a lot easier if you can do this with the Bovie. The scissors of the robot are particularly underpowered for use removing an old prosthesis, so it's a good bit easier to do it that way. Once it's removed from the annulus, then you got to get it out of the heart. You have to extend the working port and unite it with the camera port to make a large enough thoracotomy and remove that. Then we place our sutures through the annulus, and this is best done starting at the 11 o'clock position and then moving in a counterclockwise manner. And here we are working around the back part of the annulus. Once these are all in place and these have been exteriorized, then we pass them through the tricuspid prosthesis. It is seated here, and then we're able to secure it with core knots, and that's done by the tableside surgeon. Once we've got all those secured, then it's a pretty simple matter to close the right atrium. And because we leave the pericardium adherent to the right atrial free wall, it's really particularly hemostatic, and we've had a good bit less bleeding when we've approached it this way. Postoperative TEE shows a well-seated tissue prosthesis in the tricuspid position with no leak. And one of the nice things about doing this without it being arrested is you can see if you interrupt the conduction system, and she had no issues with that. Our operative time was just a little over 2 hours. Our pump run was only 90 minutes. There was no cross-clamp time, no transfusions. She was extubated the day to surgery and was discharged on postoperative day 5. We like doing the redo tricuspid valves with a robot unarrested through the right chest because we think it's particularly protective of the right heart. You can replace or repair the tricuspid valve, and indeed you can move pacemaker leads out of the way if necessary. I think it's one of the important additions of this is not dissecting the pericardium or isolating the cavity has led to significant reduction in transfusion. A Swan-Ganz balloon can be used to occlude the superior vena cava if you've got significant air coming from there or too much volume in your face. And we usually are able to handle air from the IVC by dragging that cannula below the diaphragm, but if it continues to be an issue, on a couple of occasions we've used a coda balloon to occlude that orifice. Usually all you need is 1 or 2 sump suckers placed in the right atrium, and that'll provide adequate exposure and removal of blood. We thank you for your attention, and we'll be happy to take any questions you might have.
Thanks a lot for this really exciting case. We might have time to discuss a little bit later. So before we do so, we move on to the next Live in a Box presentation, which is going to be Transapical Neocorp, and this is going to be presented by Andrea Colli from the University of Pisa, Italy. Andrea, please.
Good morning, everybody. It's a pleasure for me today to present you an overview of the Transapical Neocorp procedure. These are my disclosures. The Neocorp procedure is a transventricular off-pump echo-guided repair of the mitral valve disease, and has been already used in more than 1,500 patients worldwide. The procedure is today considered standardized and reproducible, and mostly because we have a very clear patient selection criteria based on the concept of anatomy that has been divided in simple and complex pathologies. Simple are the isolated and multi-segment posterior disease. The complex are the anterior or bileaflet prolapse, as well as paracommissural prolapses with annular or without annular leaflet calcification. Selection is also based on 2 echocardiographic screening tools, the leaflet to annular index and the coaptation length index. Both tools give us the idea together, which is about the quantity of overriding the tissue and amount of tissue that we have that can lead to a good coaptation after the procedure. The two magic numbers that identify suitable candidates are 1.2 for the leaflet to annular index and 5 mm for the coaptation length index. In particular, you can see here a case of a patient that wouldn't have an adequate leaflet to annular index, only one of index, with 1 mm of potential coaptation surface. If we do not consider to reduce the anteroposterior diameter, we will never reach a significant appropriate leaflet to annular index. So it means that this patient has a mismatch between the annulus and the leaflet surface. We put it all together, this information, in the so-called Neocorp success rate predictor, and today is available for free online. And we can identify ideal and good candidate, possible candidates, and unsuitable candidate based on different characteristics of the mitral valve, the echocardiographic representation of the leaflet, as well as the dimension of the ventricle. We have also learned that more than a Transapical is a transventricular procedure, so we wanted to achieve a lateral access to the ventricle in order to create a balanced fan of cords that is symmetrically balanced, giving a symmetric distribution of the tension of the cords. We can move a little bit more anterior the access site only once there is a not perfect leaflet to annular index. So in this way we can stretch the posterior leaflet below the anterior and increase the coaptation. We have also learned how to use the device inside the ventricle. Very important, we have always to use an X-plane view of the valve, and we have to simultaneously view our device in both screens. Very important is also the way that we approach the crossing of the valve. We have to point the dome of the posterior leaflet, and then we have to slide with the device over the anterior in order not to entangle the device into the subvalvular apparatus. Here you can see that we have switched already, we have crossed the valve, we are already in 3D. We open the jaws of the device, we target the point of the valve that we want to treat, we gently retrieve the device up to the point that it's in between the jaws, we close the device, we puncture the leaflet, and we retrieve the device together, leaving the cord in place. And this is real time, showing that is not a technically difficult procedure. After having implanted the number of cords that we consider appropriate, we have to tension them. To do so, we have to trim a Teflon pledget. All the cords are passed through this Teflon pledget that is fixed over the apex on the previous pledget of the purse strings that we used. We always follow the same symmetricity of the implantation of the cords in order to be precise after to tension them. Each cord is passed over a single tourniquet, so there is a tourniquet for each cord, and we gently with the mosquito start tensioning, and we with our tactile feeling check and double check again the tensioning of each cord in order to be precise in making the final overtension and over the tuning that we want to achieve, like in the images that you see below on the upper screen, in which there is this overtensioning that allows to prevent the so-called relative elongation after reverse remodeling. And then we make the fixation over a right angle clamp, making several knots on each pair of cord, and then the procedure is finalized and we have just to close the pericardium. Today we have also a new tool that is the biosimulator, that is part of the training that we have to perform before going into humans, and I think this has been a very important achievement for reducing the learning curve of this procedure. In terms of result, we have seen that simple anatomies present good results up to 3 years, and more recently showed up to 5 years compared to complex anatomies. We have also observed a significant reverse remodeling of the left ventricle dimensions and the left atrium dimensions, as well as a maintenance of this reverse remodeling up to 2 years after the procedure. The procedure has been used not only in isolated cases, but also as a combination of therapies with annuloplasty devices. It's been used as an edge-to-edge with Neocorp implantation in special conditions in which was not possible to implant a mitral clip. In combination with mid-cap, it has been used also to treat patients already repaired that had a failure of the repair with a recurrence of regurgitation because of rupture of cord. As you can see here, with achieving good coaptation already with the annuloplasty implanted. It has been also used to enlarge, making a leaflet augmentation in patients with a restricted motion of an anterior leaflet. And this is the new device that will come in the next years, that is version 2.0, with some new features that would make easier the procedure. And very important, there will be very soon the first in human of the transcatheter transseptal mitral cord repair that will mimic the transapical procedure to a transfemoral approach. So, in conclusion, the transapical Neocorp mitral valve repair is a standardized and reproducible procedure. Technical refinements have led to improved outcomes up to 5 years, showing a stability of ringless procedure in selected cases. And very soon we will have a transfemoral first in human that will most probably give us new opportunity in this field. Thank you very much for your attention.
Thank you, Dr. Colli. Our next presentation is an abstract presentation entitled How I Do It, Robotic Endoscopic Mitral Valve Repair Video, to be presented by Dr. Caroline M. Comlow of the Division of Cardiac Surgery, Department of Surgery, Thomas Jefferson Hospital, Philadelphia, Pennsylvania. Take it away, Dr. Comlow.
My name is Caroline Comlow. I'm a fourth-year medical student at Thomas Jefferson University Hospital. I will present a video titled How I Do It, Robotic Endoscopic Mitral Valve Repair on behalf of Dr. Sloan Guy. This is the pre-op TEE, which shows severe MR with severe P2 prolapse and an anteriorly directed jet. This slide simply outlines the conduct of the operation from port access through decannulation and includes the location of surgeon at bedside versus console. Here we have the ports placed in a patient. You can see the 8mm air seal working port, as well as the endoscope port, as well as the angiocatheters that are used to exteriorize retraction sutures throughout the operation. We use percutaneous cannulation for cardiopulmonary bypass for all of our robotic patients. This is an extremely choreographed component of our operation. Here's a photo demonstrating percutaneous cannulation of the femoral artery and vein with ProGlide pre-closure devices placed on either side. To prevent injury to the diaphragm, we place a retraction suture, which is then exteriorized through an angiocatheter. Cryoablation is performed from T3 through T9 on the right side to stun the intercostal nerves and reduce postoperative pain. We stay on the right side more than 5 centimeters lateral to the spine with 2 minutes at negative 60 degrees Celsius. Here we are opening the pericardium from over the IVC to the aorta. With the pericardium open, we place retraction sutures using CV2 Gore-Tex sutures, which are then exteriorized through an O-silk loop, which is pulled through the angiocatheters in the right lateral chest wall. 10 performed. You can see the left atrial retractor come in. This is a PFO that we close with the 3.0 V-lock non-resorbable barb suture. We'll run this in a double layer fashion. With each pull of the suture, the barbs lock the tissue. We feel this gives us a very nice closure, and as you'll see, there's no need to tie whatsoever. This suture is simply cut once we finish our double layer. Following the PFO closure, we place two 2.0 Ethibond sutures from the left atrium tacked down to the pericardium. This is to optimize exposure of the posterior annulus. Those will be cut down later, removed later. And then we begin left atrial appendage closure with another 3.0 V-lock non-resorbable barb suture. Here you can see the suture line, and we believe that both this 2.0 ethibond and the left atrial appendage closure give us very nice exposure of the mitral valve. We close the left atrial appendage on virtually all of our patients with this 3.0 V-lock suture. We decided to place 2 sets of neocords, one from the anterolateral papillary muscle to the left-sided P2, and one from the right posteromedial papillary muscle to the right-sided P2 in a standard fashion. These neocords are adjusted dynamically under static testing and ultimately tied down to achieve optimal coaptation. As you'll see, the 8mm incisions we use require a paper-based sizer, so we sized this annulus to a 32mm Edwards Cosgrove flexible band, which we secure to the annulus with 2 3.0 V-lock sutures, and they are run in a horizontal mattress fashion, starting at the trigones and then meeting in the middle of P2 where the sutures are secured. And as you will see, they're cut, they're not tied. So we're starting with the second V-lock suture. To secure this band. And again, cut. We close the atrium by starting a V-lock suture at either side, on both sides of the atriotomy, and running the suture towards the LV vent, which is placed across the mitral valve. This allows for de-airing maneuvers to occur. Following atriotomy closure, decannulation proceeds.
Thanks, very nice demonstration of elegant technique. I think we have some time now for Q&A. So we have actually 2 questions coming in from the audience for the tricuspid redo robotic case. So I think this is one from Clifton Lewis. So one question was, how do you handle the pacemaker wires? This is obviously kind of a tricky question. And the other one is more in regard to the indication. And it is, have you considered a catheter transjugular valve-in-valve as a sapien prosthesis?
So in terms of the pacemaker wire, you know, if it goes across an old prosthesis, a porcine prosthesis, we haven't run into that yet, but what we do is take it out just like we showed it, and we pull it out and take a big scissors and cut it in 2 and drag it out. And then we would tuck that into our suture line and just going to go around the valve. It's a lot easier when it's you're doing a repair, and we didn't show a video of that. Most of ours are repairs, and they're just simple bands, and so you just work your way around all those pacer leads. In terms of femoral or jugular implantation, we have done a few S3s, valve-in-valves, and you know, the procedural success long term, I'm not really sure. This is a fairly young patient, and I think it's probably better to put a new tissue prosthesis in. We're working on some of the early in-man feasibility studies for one of the new transfemoral TTVR platforms, and are currently you know, looking for patients. I think this is like a lot of percutaneous versus minimally invasive versus sternal incisions. There's not going to be an all or none for any of them, but I think they all will have their applicability.
And unfortunately, that's all the time we have left for the group discussion. Thank you, Dr. Lewis and Dr. Kamlo, for being with us here, and Dr. Coley, who wasn't able to join the discussion, for being us with here today. We're going to move into section 2, cardiac section 2A, with a segment on minimally invasive solutions to heart failure. Our first presentation within this segment is titled New Pulse CV IVAS, Serving as a Population Beyond LVADs, to be presented by Dr. Val Juvenandam, University of Chicago, Chicago, Illinois. Dr. Juvenandam, take it away, please.
Hello, I'm Valuvan Jeevanandam from the University of Chicago Medicine, and today I'm going to be talking about the New Pulse CV IVAS, serving a population beyond LVADs. I don't have any disclosures. So ambulatory counterpulsation can be used in several ways. Oftentimes, the balloon pump is the first line therapy for circulatory insufficiency, and this is placed percutaneously via the femoral approach. Can be used for post-cardiotomy, decompensated chronic heart failure, weaning off Ecmo, etc. In this scenario, oftentimes hemodynamics stabilize, but then you're unable to wean the balloon after 2 to 3 days. These patients benefit from long-term support and ability to ambulate. We've done this at the University of Chicago Medicine by switching to a subclavian access balloon pump, either by a percutaneous or a grafted approach. To be able to send patients home, we then adopted a technology called the New Pulse CV IVAS. IVAS stands for Intervascular Ventricular Assist System. You can see the subclavian arteries accessed through a arterial interface device. There is a balloon placed in the descending aorta, and the drive line is all tunneled underneath the skin to a skin interface device, which then interacts with a 7-pound ambulatory counterpulsation device. Why IVAS? It's an intermediate solution between patients who have CRT failure and LVADs. As you can see here, you have NYHA class 2, 3, 4, and 2, 3, and 4. LVADs are actually approved for class 3Bs and 4s, but in reality, 80% of the LVADs are implanted in a very small population of the class 4 patients. Therefore, there is a large unmet need for which IVAS was designed. It has a favorable AE profile versus LVADs in that it requires very low anticoagulation. It's minimally invasive, not requiring cardiac or thoracic access. It allows for quick recovery and robust rehabilitation. If patients have some hemodynamic reserve, they can be disconnected for prolonged periods of time. It allows a great physiological environment for recovery, and it is very versatile. The IVAS underwent the feasibility trial. In this feasibility trial, the primary outcomes were transplant or 30-day stroke-free survival on IVAS. You can see the secondary outcomes, and inclusion-exclusion criteria include a subclavian of greater than 7 millimeters of mercury, resting heart rate less than 100, and less than mild AI. In 2016 and 17, the first in-human trial was done at the University of Chicago Medicine. Those were the first 14 patients. The feasibility trial phase 1 was patients 15 through 45, done in over 10 hospitals. And then to date, the feasibility trial phase 2 is nearing completion with 81 patients implanted to date, and the pivotal trial has FDA approval. This is data on the first 44 patients. You can see the average age of 58. Most of them were Intermax 3s. 31 were listed for UNOS transplantation. 13 were used as a bridge to decision. There were 4 deaths in this group. There was an 88% successful transplantation rate. The length of support was extended, was 65 plus or minus 75 days, with 4 patients going over 6 months. You can see the adverse event rates were very low. Infection was low. These are the hemodynamics for the first in-human patients. So you can see it decreases CVP, PA pressures, and increases cardiac index and cardiac power. Functional assessment, they improved their 6-minute walks, and this was statistically significant. they improved their KCCQ cardiomyopathy questionnaire. So you have a device which can be implanted minimally invasively that has good functional and quality of care improvements. This trial was done with all these partner sites. Over 28 sites were trained to do these sites, to do the implants, and about 15 actually performed implants. So in summary, the IVAS feasibility trial showed that it provides hemodynamic support, especially in patients who have some myocardial reserve. It has a very justifiable risk benefit ratio with low adverse event rates. It's minimally invasive. It does not require access to the chest. The patients improve functionally and with symptoms. And in a separate sub-study, we showed that there is signals for positive remodeling, and that makes this possibly the only device for not only treating heart failure with reduced ejection fraction, but possibly for patients who have moderate or preserved ejection fraction as well. We have shown that it's versatile and it's an innovative device that can help patients, particularly get them to transplantation. And at the current time, a percutaneous version of this device is being developed to allow implantation in the cath lab. These are some of the patients. This was the first patient who actually was allowed to leave the hospital. This patient is taking his first breath of fresh air in weeks. This person ended up going to a Cubs game. First patient discharged who went home and was eventually bridged to a heart kidney transplant, and a patient who did some work at home, and a patient got married on the device. So thank you very much, and hope that you'll be hearing from us soon when the pivotal trial is underway.
Thanks a lot for sharing your experience with this new device. We stay in the area of temporary extracorporeal circulatory support, and my colleague Evgeny Potapov from Berlin is going to demonstrate with you the concept of Ecmo version 2 via a single arterial access. Evgeny, please.
Good morning, ladies and gentlemen. I'm glad to present our experience with Ecmo 2.0 single arterial access. This is my disclosure. So the Impeller alone is not the best device for severe cardiogenic shock. In patients after cardiopulmonary resuscitation, the survival is very bad, and in patients with elevated lactate over 8 millimole per liter, the survival is also diminished, the red line. So SLS has advantages over the Impeller because of higher flow, but due to peripheral access, high risk for limb ischemia or vascular complications. And if it's femoral cannulation, risk for Harlequin syndrome if the left ventricle start to eject, but lung do not work. So, and open chest for central cannulation. So we say VA SLS alone is not the best device for severe cardiogenic shock because it does not unload the left ventricle, and therefore no left ventricular recovery is facilitated, and it is high risk for lung edema and also for Harlequin syndrome. So therefore, the combination of Impeller and SLS, Ecmo 1.0, is a good solution. It does unload the left ventricle and right ventricle, facilitate myocardial recovery, and provides lung support and prevent lung edema. However, the most complications in such patients are due to second arterial access, and also the delayed Impeller implantation and Harlequin syndrome are still a problem. So the solution is Ecmo 2.0 single arterial access. I show you some video how to do it. So first we use fabric-made graft, is a Y graft, as you can see. the graft is cutted accordingly. So the axillary artery is prepared as usual, and then the graft is attached to the axillary artery. First, we measure the length of the graft because the junction should be outside of the skin. So as you can see it here. And so we cut the one branch is for Ecls cannula, and the second branch is for insertion of impeller, as you can see it here in this picture. So the length of the branches should be measured accordingly. So then the graft is attached to the axillary artery as usual. So after the graft is attached, it's tuned to outside. And the impeller is implanted through the one branch under fluoroscopic control and echocardiography. The second branch is clamped and will be used later for Ecls access. Important is to implant the impeller first, because it will be difficult to pass the arterial cannula. So the impeller is implanted over the wire, as you can see here, and started. And if the support is enough, you may stay with impeller alone. If you feel that impeller alone is not enough, the additional Ecls is implanted. In our situation, we implant Ecmo 2.0 always after resuscitation, and patient after resuscitation or with lactate over 8 millimole per liter. So the cannula is implanted over the wire under fluoroscopic control. Fixate in the branch. Connected to the arterial line of the Ecls circuit, fixate, and then the venous access is provided in the right femoral groin. The venous cannula is implanted in the usual fashion, then under echo control and connected to the circuit. So this is the setting: one graft, one single arterial access for impeller and arterial cannula, and also the venous cannula in the groin. So the Ecls pumps 5 liters and impeller vents left ventricle with 2 liters. So, and de-escalation is also very easy. Bedside in the ICU, just clamp and remove arterial cannula from the branch, clamp the branch, ligate it is, and the same is for the venous cannula. The venous cannula will be removed for the groin and secure as usual. So this combination may provide up to 11 liters flow, as you can see here, 6 liters on the Ecls and 5 liters of impeller, which is very important. Patient in SIRS situation, high perfusion is led to reduction of vasopressors. So, in conclusion, Ecmo 2.0 single arterial access is the best device for severe cardiogenic shock. It provides maximal cardiopulmonary support with up to 11 liters. It is central ACLS, no Harlequin syndrome, but LV unloading, it's a balanced LV and RV unloading and support, the single arterial access, closed chest, and no growing complications. Mobilization is possible, especially if the venous drainage performs through a jugular vein, and de-escalation and removal of ACLS on the bedside is possible and easy. Thank you very much for your attention.
Thank you, Dr. Potapov. Our next presentation is titled Minimally Invasive LVAD by Dr. Pia Landmuller, joining us also from the Berlin Heart Center in Berlin. Dr. Landmuller, the screen is yours.
Good morning, ladies and gentlemen. Thank you very much for the invitation to speak to you today about minimal invasive LVAD implantation. My name is Dr. Pia Landmuller, and I'm a member of the MCS team at the German Heart Center Berlin. I have no disclosures. After the introduction of intrapericardial centrifugal pumps, with their smaller size and the better usability, minimal invasive LVAD implantation became more and more popular. Basically, there are two forms of minimal invasive LVAD implantation. One's the hemistenotomy with a 4 to 6 centimeter skin incision with a stenotomy up to the second or third intercostal space, combined with a left thoracotomy. On the other hand, there is the right anterior mini thoracotomy in the second intercostal space, combined with the left thoracotomy. There is the so-called sternum sparing technique. In case of hemistenotomy, you can either do arterial cannulation at the ascending order. With the sternum sparing technique, only the femoral vessels can be used for cardiopulmonary bypass. For full completeness, I want to show you the less invasive LVAD implantation approach. Therefore, you perform a left anterolateral thoracotomy in the 4th to 6th intercostal space. Usually you only need one skin incision, but it's a bigger one with up to 10 centimeters. In this approach, the outflow-graft anastomosis is performed at the descending order. It's especially preferred in redo cases with patent grafts. Now I want to show you a film where we did the sternum sparing technique in a 70-year-old patient with ischemic cardiomyopathy. Now you can see we put wires in the femoral vessels just in case for cardiopulmonary bypass, but we decided to do off-pump implantation. Now we did skin incision, put a soft tissue retractor in the second intercostal space, and meanwhile opened the pericardium. After we did that, we fixated the pericardium and tunneled the outflow graft. Now we prepared the position for LV coring and did partial clamping of the ascending order to perform the outflow graft anastomosis. Now you can see the Gore-Tex prosthesis at the outflow graft. It's used to prevent adhesions or any kinking, and then we perform the 12 sutures to fixate the LVAD ring to the apex. Now you can see we tunnel the driveline with a pleural train in a C-shaped technique. And then attach the outflow graft to the pump. After we introduced rapid pacing, we performed the LV coring. Rapid pacing we use to prevent blood loss. And now you can see the coring. And then the LVAD pump is implanted and fixated. After that, the surgery is finished. Now I will continue to the next slide. So what are the benefits of minimal invasive LVAD implantation? Once the avoidance of adhesions, less surgical trauma, less adhesions, and the outflow graft is located lateral to the right ventricle. So this has the benefit of an easier surgical approach in case of future heart transplantation. And on the other side, during LVAD implantation, you have excellent exposure of the left ventricular apex. Therefore, you don't have to do a lot of manipulation of the heart. And this, in combination with the preservation of the pericardial restraint over the right ventricle, should have a reduced incidence of right ventricular failure after LVAD implantation. But the big limitation is any need for concomitant procedures. However, the transcatheter or aortic and mitral valve replacement becomes more popular and is described in case reports. And the transcatheter closure of patent foraminal valve is often used interventional procedure. Now I wanted to show a meta-analysis and systematic review of 13 retrospective cohort studies where sternotomy approach and thoracotomy approach are looked at. You see the most often used approach is the mini sternotomy, and off-pump implantation is more often performed in the thoracotomy approach than in the median sternotomy. Meanwhile, the concomitant procedures are more often in the sternotomy group. So what are the results? There is a reduced incidence of RV failure, but no difference in LVAD use, and reduced incidence of exploration for bleeding and perioperative blood transfusion. But there is no information about 1 year survival. Nevertheless, there's a reduced perioperative mortality, and there's no difference in stroke rates. Then I have another multi-center retrospective cohort study where you also have a reduced incidence of right heart failure, but no difference in 30-day or 1 year mortality. So what are the conclusions? Less bleeding, less blood transfusion, faster hospital discharge, which are big advantages, but no reduction of perioperative stroke rate and no better midterm survival. So only prospective randomized studies will answer all the questions. Thank you very much.
Thanks a lot, Pia, for this elegant presentation. So we stay within the ECLS for one more presentation until we reach our group discussion. And the next one is going to be presented from Danny Ramsey from Cedars-Sinai in Los Angeles, California. It's unfortunately a very kind of important topic over the last year, and it is going to be ECMO in COVID patients.
I'd like to thank the Society for the opportunity to present today, and I'll be presenting on ECMO and COVID. I have the disclosure seen here in this slide. Severe acute respiratory distress syndrome coronavirus 2, also known as SARS-CoV-2, results in what we commonly call COVID-19 disease. Its main prominent feature in the critically ill patient is the development of severe respiratory failure and ARDS. Early in the pandemic, the use and data on ECMO was limited, and as time progressed, we gained further knowledge on this disease and on ECMO in this disease. My three objective is to just discuss a little bit of the pre-pandemic historical data and the current data and recommendations and guidelines. When we see ECMO usage in the ELSO registry, we see a significant rise happening in the last decade in around 2019 and 2010. This was a result of another virus resulting in severe RDS. At that time, it was H1N1. And we've learned a lot since then and developed our guidelines from ECMO, principally from this knowledge and knowledge since then. When looking at the ELSO registry outcome for VV ECMO prior to the pandemic, we see about a 59% survival at discharge. In terms of the standard technique and for ECMO and dual lumen VV ECMO technologies, we see here the two-stick technique, and as well as the single lumen technique that's been gaining rapid adoption for a single stick, promoting more easy nursing care and ambulation, and reduced mixing and recirculation. newer cannulas, such as the Protect Duo, which performs both the RV type support as well as VV ECMO type support, has been increased in use. And the group in Chicago have been using this cannula in COVID ECMO with good results. Now, focusing on ECMO and COVID, looking at the ELSO registry, there's been a significant use of ECMO for COVID, over almost 7,000 cases, with the ELSO registry showing about a 50%, 51% hospital survival, very similar to prior to the pandemic. When looking at competing outcomes, you could see here approximately 50% mortality with these patients. In the updated 2021 guidelines, ELSO recommends early use of VV ECMO in these cases instead of using salvage ECMOs and And deferral of ECMO have been shown to potentially be detrimental, and any benefits gained from waiting to initiate ECMO could be lost. And here's the algorithm, a very simplified algorithm that centers can use. In terms of the recommendation during support of these patients is aggressive management to prevent thrombosis, both venous and arterial. Early tracheostomy and proning of these patients have been shown to be extremely beneficial. Again, we must protect our team with heightened awareness of strict PPE protection for our team and our staff, and mobilizing these patients as soon as we can. There are some hints and indication that it may improve outcomes. And yes, proning is possible with VV ECMO, and proning is possible in large patients. Key ELSO recommendation is to utilize ECMO in these patients as we've done pre-pandemic. And I think that is sort of the key current message with these patients, and to mobilize them as early as possible when feasible. So the survival with VV ECMO in COVID-19 is similar to historical data. It should be considered and used as previously indicated, as we've now seen that the outcomes are very similar. But the main difference is that these COVID-19 may require longer run times than previous pre-pandemic, even in the months of support range. It is a finite resources, and the understanding is that especially during surges, that the ICU bed crunch and staffing crunch can happen, and therefore stricter criteria may be needed for these COVID-19 ECMO candidates. Our knowledge has been rapidly increasing, and I'll discuss a few manuscripts here. One is by Barbaro and his colleagues. They've seen a 90-day survival of 62%. So good outcomes can be achieved with these patients, particularly younger patients, as you can see here, have favorable outcomes, and those with less comorbidities. So those are factors that may come into play if resource crunch occurs. And this is, again, similar to pre-pandemic numbers, where you could see 65% 60-day survival. When we get down closer to determinants of outcomes, we see hospital experience, so pre-pandemic caseload of greater than 30 cases in the previous year have better survival than those that did not have that. Younger patients, as you can see here, have better outcomes. In the time between intubation and ECMO, so the early initiation of ECMO also has favorable outcome, and those are all characteristics and determinants of good outcomes. Again, looking down now at the US data, ECMO within 7 days, as the ECMO group within 7 days had better survival than those that waited. What about complications with ECMO 19 versus ECMO and COVID-19 versus ECMO non-COVID patients? As you can see, there's no difference in ECMO complications. Therefore, these patients should be treated and as very similar to those pre-pandemic. When examining COVID-19 and non-COVID-19 survival during this pandemic, you can see there's no difference in survival. One could say that survival may be a little bit lower than pre-pandemic, and that may be due to the resource crunch and higher staff, higher demands on staff, but there's no difference in survival between the two groups. So, in conclusion, indications for ECMO initiation in COVID-19 should be unchanged compared to the pre-pandemic. Conventional therapies for ARDS should still be established and done, and prone positioning should be utilized. delaying an ECMO initiation has not been shown to have any survival advantage, actually survival detriment on these patients. Therefore, we should not delay ECMO initiation. The only time consideration for ECMO delay is time during research crunches or during surges, where when we have limited resources and we may want to place those that are the more optimal chance of survival. Thank you.
Thank you, Dr. Ramsey. We will now like to open this up for discussion. A reminder to everyone, use the QA function to the right of your screen to ask questions. The question I saw from the audience, from the Q&A, Dr. Popov, how does the ECLS flow affect the flow of the Impella? Is there a communication there? I'm sorry, you're muted, Dr. Popov.
So they work together. The first, the Impeller unload the left ventricle. If the right ventricle does not work properly, it is not enough volume in the left ventricle. In this case, Impeller pumps maybe 1 to 2 liter as a vent. With the improvement of right ventricular function, the Impeller flow increase. So you have to balance this using echo and look at the right ventricular function. And in patients with volume as a resuscitation for shock, in these patients, you can achieve really up to 10, 11 liters flow, and they need this high perfusion due to Sears phenomenon after resuscitation or after deep shock.
And do you have any problems with the arm, with swelling or flow or other issues with the right arm or the?
Yes. Sometimes it's overperfusion, and I recommend to put arterial line on the right side, in the right radial artery, or left, depends where you did implant Ecmo 2.0, and monitor the pressure after the access. So if the pressure is a pressure difference over 50, so I recommend to constrict the distal axillary artery. You can do it as well percutaneously. You put just a loop and take it out far away from the wound and constrict and pull a little bit up so you can reduce the flow to distal. But again, it is approximately 10% of the patients who develop overperfusion. Usually the axillary artery regulate the flow by themselves.
Thank you.
Thanks, Evgeny. So I think this was within the Q&A, we saw a couple of questions in regard to the new Pulse system. And the question are typically in regard to where's the actual difference between a classic balloon pump and this new device. So I think it needs a little bit more clarification of the concept itself.
So great, thank you very much. The new Pulse device is designed for ambulatory care, right? You can't go home with a balloon pump. So this is designed to be a very, very long-term balloon pump. Our longest implant to date has been over 14 months. And that patient spent almost, other than 5 days in the hospital, spent all that time at home. And so that's the biggest difference between this and a balloon pump. The type of support it gives is a little bit more support with new Pulse because the balloon is configured a little bit differently and it's a stiffer balloon, so it provides better counterpulsation. I also see other questions in my chat about the 6-minute walk test. So remember, these were paired 6-minute walks. Most of the other studies don't have paired 6-minute walks. And these patients who started off at 1,000 feet were on inotropes. I think all except one patient was on inotropes. And by the time they got new Pulse and they had a 23% improvement in 6-minute walk, they were not on any inotropes. And there was a question about local infection. So this pump is exteriorized with a thing called the SID, which has a geometric and physiological it's a shape and a surface treatment that prevents infection. So out of these 44 patients, only 2 patients ended up having any type of infection. And a lot of that was because of, again, this was the first in human study. And we realized some of the strategies in terms of anchoring that we need to do. And then in the last portion of the study, the infection rates were eliminated.
Thanks a lot. So I guess this was kind of a very exciting session with lots of great presentation, new techniques, and we could easily stay another half an hour to discuss all these kind of tiny details. Unfortunately, we don't have the time to do so. So thanks again to all the speakers, and we need to hand over to the live studio to continue in the program. Thanks again.
Thank you, everybody.
Welcome back to the live studio. Wow, that was another terrific start to the day, amazing presentations. As we have mentioned before, this meeting would not be possible without the support that we have received from industry partners, and we're extremely grateful from them. Having said that, we're thrilled that the next industry symposium is from AtriCure, and they'll be presenting on heart team approaches for challenging atrial fibrillation patients, key evidence, and procedural learnings. Please note that this symposium has been pre-recorded, so there will be no live Q&A questions and answers. And we'll be back again after this particular symposium. AtriCure, please take it away.
We didn't have silence in the studio. Nice job, man.
Good day, everyone, and welcome to ISMICS Reimagine 2021, to the AtriCure Symposium.